happened? Did I lose it? Oh, crap.
Be careful. We can hear everything that you say. If you're having trouble with the webinar, there's a help number, hopefully, that you can call because we can hear your consternation there.
Well, let me go ahead and kick it off a little bit with, I'm going to kind of jump down to item C. I really appreciated the boots on the ground and making it real ideas that Dr. Bergeson and Janet Weed shared with the group from Alina Health. So one of the things that we undertook within the Oakland Southfield Physicians PO is we had a broader seminar where we had lots of participants, folks involved in the MyPAC initiative were there. And one of the things that we heard from this feedback session was how important it was for folks who are being measured. The audience included staff and physicians to actually take the survey and know what they're being measured on. So based on the encouragement and what we learned during this session, we went ahead and did that. So all participants had a custom survey based on their specialty. We played some Jeopardy music, took the survey, had some fun, certainly went through it in a rather fast-paced way, since the survey can take a little bit of time to complete. And then we kind of unpacked it and talked about it as it related to those different domains. One of the things that came out of it, we heard Janet mention, was really that coaching in advance of the clinician physician walking into the exam room. Hey, Jenny, what are you here to see me for? When perhaps patient Jenny had already said that to 5 people before the doctor walked in the room, and that really was a frustration point for me because it seemed like a complete lack of communication and coordination. So removing that very typical nomenclature that each of us are used to hearing from our physicians and certainly as patients ourselves it was going to change overnight, but that was one of the things that we really tried and are continuing to try to message as it relates to the very important provider communication domain within the work. So that was one of the things that we took away, and it was tangible, didn't require a lot of certainly costs, but it just required the effort and commitment of our team to do that. So I share that. Anyone else do anything based on what they heard, even if it was really little?
Thanks, Jenny, for that. This is Donna Saxton. I unfortunately wasn't able to attend that webinar due to a scheduling conflict, so I really appreciate your thoughtful comments.
You're welcome, Donna. Thanks.
So there was
hi, this is. Oh, go ahead.
No, go ahead, Tom.
I was going to say this is Tom, and I was unable to join the webinar as well. But I know, you know, we have been at, as some of you know, we have been at this work for in our physician network for at least 5 years, and we're pleased to see, I would say, slow and steady year-over-year improvement in our work, and we have dedicated a considerable amount of resources to the efforts. We started out being physician-led, and we continue to be physician-led because we felt within this particular area of a healthcare organization, just as the survey is designed, you notice that the vast majority of questions are either on access or on provider communication. And elements of care coordination, of which the provider is really can be at the root of all of that in a good or bad way. And so physician, in partnership with myself and a couple others, we looked at one-on-one coaching of physicians. We transitioned to more physician group coaching where there is an interactive approach to observation of coaches, role-playing, and we always say we're not looking for significant transformation of the physician themselves, but rather looking at it from what can we modify or tweak that would significantly enhance the experience without really changing any of the makeup or interpersonal, I would say, makeup of that provider. And so with that, we have seen year-over-year improvement. I would say we continue to be challenged with access, and so a lot of our activity right now is looking at how do we improve the access work. But I will say, you know, I want people to assure folks that had we looked at our first year to second year improvement, given the resource commitment that we made, we probably would have felt like we failed miserably. But we stuck to it, and we continued to revise and gather feedback from internal staff as well as other providers to say, how do we change this to continue to evolve it? And it is a long process. It is change management, which is not easy. And so there is a sense of, like anything, it's almost a lifestyle change of moving into and trying to sustain that. So it's really been around being physician-driven and led, around provider communication, and now moving to the access piece that we're focused on.
Jenny and Tom, this is Lisa, and I'm wondering if anyone followed up on the suggestion made in the webinar, or excuse me, in our last meeting, that we all review the actual survey, and were copies, you know, we sent a copy of the survey out. Did anyone share that with the, did any of the POs know that their practices are sharing that with the staff and physicians in the offices, the actual survey?
This is Bob. One of the takeaways we were hoping to get out of this discussion, this agenda topic was ways to improve future webinars. But maybe to try to get some more feedback and discussion going here, I could take it back to a little bit higher, more general level. What did folks think about the idea of having structuring these webinars as beginning with a subject matter expert giving a presentation on the topic that's being focused on, and then opening it up for questions, dialogue around a topic that may be of interest to folks, and the like.
So what did folks that attended the webinar think of that format?
This is Carla. I think it's a good format. I just think sometimes it gets lost in individuals have the good intentions on listening and participating and being engaged and involved, but you know, their present location distractions sometimes supersedes what's going on the WebEx. So I think, and I get logistically why we need to have webinars, but I think sometimes doing, you know, breaking it up with maybe an on-site once in a while is going to be helpful.
So reality sometimes gets in the way and we get distracted during webinars.
Yeah.
Thanks, Carla.
Competing priorities. Yeah. I know that, and to your earlier question, Lisa, We have shared the survey with our physicians and the office managers and encouraged them to review it with their staff and also have them take the survey themselves as if they were the patient, just to kind of put the physicians and or the staff in the mindset of what are these patients being asked.
Oh, that's great. So did some of the practices do that, Carla?
Yes, they do it. And a lot of the physicians, again, it's how the questions are worded, and a lot of the physicians or staff are like, well, we do this, but we don't word it this way. It's not, so it gets into semantics and then the perception. So they're doing the work, it's just not worded the way the survey has it, and they can see where the patient's perception is, the patient's perception on the question being asked, and it impacts their score that they get. So it's just educating them on what exactly is on these surveys.
Sounds like they found it very revealing. That's great that you suggested they do that. Thank you, Carla.
Lisa, this is Tom, and again, like I said, I was unable to attend the webinar, but I do think the challenge is I kind of my perspective is we've been at this for 5 to 6 years in this part of our organization. We've been in the inpatient world, ED, and others for far longer. I think trying to just understand where each of the POs or offices are where they're even at in their journey. A webinar, is there like the 101, the basics, the basic key elements, and building it towards almost like a curriculum type of approach might be helpful. Again, I think to the person earlier, I think it was Carla that mentioned, if it's a webinar and it is about just getting familiar with the survey and doing some of those things, that's not probably like finding a high value for our organization or me or people in our organization. We're into more of the advanced analysis and advanced things that we've implemented a lot of I would say the first tier of changes and work. So how do we maybe build the webinar? I'd be curious to know what others think about that. But trying to really gear the webinars around where people are at in their journey, so that it's more targeted and more applicable. We might have less attendance at certain ones, but it might be of more value to fewer people.
Thanks, Tom.
Hi, this is Jenny. So I'm tempted to go. Could you repeat that question? No, I'm not distracted. I promise I'm focusing. So what I've heard so far is that, the reality of the limitations around the webinar. It sounds like the broad brush versus narrow focus. This is a huge collaborative, and we're all on varying degrees of sophistication on our journey to improve the patient experience of care. I didn't hear anything contrary to the question that Bob asked, so I think that as a group we agree that hearing from content or subject matter experts first, and then having that open dialogue to ask them questions, make it real. I don't have any issues with the format, nor do others on the line, hearing no reservations. What we've heard, though, is that maybe we need to almost have varying levels based on the content that is shared. And there's a couple different ways that we can do that. We can certainly take that back with Bob and Lisa and think about it. A blended version where there's different kind of chapters that are touched on in one session, or just offering multiple so that you can speak to those who've been doing this and are more at an advanced stage of implementation, like Tom shared with his group.
I think that's a really good summary, Jenny.
So hearing no further discussion on that, I'd like to move on. We'll go on staying on our agenda timeline here. Let's go to item 3, which is the round 3 performance targets. As Tom mentioned earlier, at the September work group, we saw the MyPEC Round 2 performance results as compared to the target that was part of your packet, attachment 2 and 3. With that, I want to turn it over to Bob to walk us through the results and spend a little bit of time on this agenda item for about the next half hour or so, with our mindful focus on the fact that we need to achieve consensus on our round 3 performance targets before we move on to agenda item 4. So Bob or Lisa, I'll turn it back to you to walk us through the information.
Thank you, Jenny. As Tom mentioned, we initiated this discussion of round 3 performance targets at our September meeting, and the focus of that discussion there was the comparative analysis that you see on your screen now. Tom mentioned some of the highlights of that discussion, but just to reiterate a few of the points, in terms of timely appointments, care, and information, 9 out of our 14 eligible POs met the composite measure for and the performance target for timely appointments, care, and information. 5 POs did not meet that one. Did a little bit better on the provider communication in that 8 of our participating POs met the target related to provider communication. 6 did not. And then with our 3rd high priority domain and corresponding composite measure of health, courteous, and respectful staff, 11 of the participating POs achieved the target associated with that domain. 3 did not. Overall, 9 POs achieved the aggregate target of meeting the targets on at least 2 of the 3 domains and attaining 2 points out of a possible 3, and 5 did not. Another point that was brought out in the discussion was that the MyPEC 50th percentile scores on the 3 domains from round 1 to round 2 did not change very much, whereas the national 50th percentile, taking into account all the participating practice sites around the country that are in the national CAHPS database, saw the national 50th percentile increase by a percentage point for each of those 3 domains. The other point is that in terms of our aggregate measures for percent improvement on each of these 3 domains and composite measures, there was a very wide range of performance across our 14 POs. So I think that's also instructive in terms of understanding what the round 2 compared to round 1 was going forward. With that, what I would like to do is move over into attachment 3, which is more focused on what we want to discuss today. In the preliminary planning discussion for this morning that Lisa, Tom, Jenny, and I had about how to prepare for this particular agenda item, we came to the conclusion that it might be a better way to get further faster if we put together a so-called straw man proposal, send it out to folks, and organize the discussion around people's reaction, thinking, and suggestions related to what's in the straw man proposal, as opposed to starting from something like a blank piece of paper and saying, what do you think we ought to do for round 3 targets? So with that in mind, as thinking of the best way to approach this topic today, I want to walk through the highlights of the so-called straw man proposal that you've now got on your screen. And the way this was structured was to highlight in red font the key elements of what the straw man is, playing from the document that you're hopefully all familiar with, which described the round 2 targets. So hitting the highlights of that, first of all, the proposal is that we again apply performance targets compared to actual performance at the PO level, or the aggregation of results for each PO, aggregating the results of each of the participating practice sites. We have a new element this time that we want to be explicit about, and that is whether or not we focus exclusively on adult survey results, or we also in some way include child results. The straw man is that only the adult survey results be used to calculate whether or not performance targets were met PO by PO. This is in part due to the fact that several of our participating POs have no pediatric practices participating and are not using the child version of the survey at all. In terms of areas of focus, the straw man is that we continue to focus on the same 3 high priority domains for round 3 targets: getting timely appointments, care, and information, provider communication, and helpful, courteous, respectful office staff. We're also proposing that we continue to have 2 ways that the target in each of those 3 domains can be met. 1 called an attainment target and 2 called an improvement target, just like we used for round 2. We are proposing, for purposes of the straw man, that the round 3 attainment performance target be set at the round 2 MIPEC 50th percentile score for each of the 3 high priority composite measures, corresponding to the 3 high priority domains I just mentioned. This would mean that for each of the composite measures, 50% of the MIPEC participating POs would meet the target for attainment, and 50% would not. Furthermore, in terms of the improvement targets, we are, for purposes of the straw man to get discussion going, suggesting that the level of improvement from round 2 to round 3, in order to meet the target, be 0.6 percentage points, which is in contrast to the round 2 target, which was a level of actual improvement of 1.0 percentage points. So this target, in terms of level of improvement, if you will, is relaxed as it relates to what we're proposing for purposes of discussion. The points threshold you see at the bottom of the page on your screen, we are proposing that this remain the same as it was for round 2 targets, maximum of 1 point being possibly attained for each of our 3 composite measures and domains, and needing to score a point in at least 2 out of the 3 domains in order to have met the round 3 targets. So needing 2 points. On the next page, I'm not going to go over this in great detail, but you'll see the same kind of example that we included for the round 2 targets, but the performance targets have been updated to show the straw man targets for round 3, and then going through the examples with made up actual performance in the third column from the left, and then the application of the performance to targets and whether or not points were accumulated and so forth. Moving through the rest of the strawman proposal, section 5, how the targets would be applied. We are proposing that it be done the same way as round 2 for round 3, meaning that for POs whose participation began in round 1, we would obviously maintain the 85% aggregate share of survey costs being paid by the plans if the performance targets for round 3 are met. Again, the straw man is that we maintain the same financial impact or penalty, if you will, if the round 3 targets are not met that we had in place for round 2, meaning the plans in the aggregate would pay 10% less or 76.5% of survey costs instead of 85%, meaning that the PO share would rise from 15% to 23.5%. POs whose participation began in round 2, we are proposing that it would be handled as proposed in the targets for round 2, that those that started in round 2 would have a 1-cycle lag compared to those who started in round 1. So for those who began in round 2, the round 2 targets would apply to them for round 3. So that's the straw man proposal. I think it's important to spend a couple of minutes talking about the rationale behind this. When you add it all up, the proposed round 3 targets in this straw man are slightly lower, if you will, or easier to attain than the round 2 targets were. And the rationale for that is as follows. As we saw from the summary analysis of round 2 performance compared to round 2 targets, we had 5 POs that did not meet the round 2 targets out of 14 that were eligible. That number, frankly, surprised us. We were expecting that and hoping that more of the POs would have met the targets. We did not set them with the expectation that some 35 to 40% of the participating POs would not meet the targets. As you all will recall, when we did the round 2 targets, It was kind of a shot in the dark. We had no prior experience on which to base those numbers. So we took a best shot at it, and the results, as you saw, were, from our perspective at least, not enough of the POs met the targets. So that's part of the rationale for proposing to relax the targets a little bit for round 3. Secondly, we are very mindful that this is a balancing act, as Tom mentioned in some of his summary comments from the last meeting. In terms of key points made, we want to establish an expectation of improvement on the part of all of the POs that are part of MyPEC. But the last thing we want to do is to set those targets so high that the POs view them as unattainable and drop out of the initiative. If POs begin to drop out of the initiative, that does not benefit any of the participating organizations, doesn't benefit the residents of Michigan and consumers who are and patients who are interested in being able to access patient experience of care information and have an expectation that this is a domain of performance that POs and practices across the state are going to be working to improve. So that's really the rationale behind this. We maybe are moving a little bit towards making the targets easier to attain in terms of this straw man, so that we hopefully increase the probabilities that everyone will stay in the program, because if we don't maintain that and build on that even with additional practices and POs, then we're kind of shooting ourselves in the foot, if you will. So with that, probably a much too lengthy introduction. Let me open it up for reactions.
This is Gina from Holland PHO. I'm wondering about the child survey. I know that you talked about how not many people are doing it, but within the participating POs and PHOs that are part of MyPEC, have you evaluated what the opportunity that they might, like a PO might start surveying for their child population might be? I'm interested from the perspective of half of our practices are doing the child survey. They're doing quite well on it relative to the benchmarks. And I would be for the fact of including them as part of the evaluation for the MyPEC initiative.
Well, that's certainly an option that is on the table. If one assumes that most, if not all, of the POs that are participating in MyPEC have the opportunity to bring practice sites that would use the child version of the survey into the initiative, that kind of takes care of the apples to apples comparison issue. Part of the rationale for the straw man was that looking again at the national CAPS database that has thousands of practice sites and tens of thousands, if not more, responses, is that on the whole, pediatric practices score higher on the pediatric or child version of the survey than is the case for the adult versions of the survey. So the thought was, if we have some POs that are including child survey results in the mix and some who are not, it's not really an apples to apples comparison at that point, because on average child survey results are higher than for adult. So that was the rationale for the straw man, that we at least for round 3 only use adult survey results. But again, that's an open question, and we could certainly come to a different conclusion on that facet of this.
Sure, I just didn't know how many people are out there, yeah, currently doing it or that have the option that could do it, and that if MyPAC had a stance of promoting that pediatric practices did in fact survey.
Yeah, I think there were 5 or 6 POs that had no child survey results for round 2. As to how many of them could bring practices into the initiative that that would presumably use those results, I'm not totally sure on that front.
Yeah, I think you've got a good framework in terms of how you've organized the table of what the domain type is and the performance target and the top box score. It would just simply be adding those child results in
Right.
relation to their respective benchmarks, and possibly even averaging what the total points are. So maybe for the adult population, I didn't hit the target, either performance or improvement, but for the child I did, and maybe you do like an average of those two together, 1 point plus 1 point, or 1, divided by 2 or whatever, for the total points possible. I think you've got a good framework to support it. It's just I've got concerns going forward in terms of MyPAC's perspective of, are we going to push for pediatric practices to do this? There's a cost associated with it for us to continue doing it, certainly. I didn't know if that was on the table or not in terms of future plans.
Yes, absolutely, on the table.
This is Robin Mitchell from Blue Cross Blue Shield of Michigan, and it seems, just to follow up on that, it seems like adding the child measures, because the PO scored higher on those, might be helpful too to bring up the averages. But one of the things I wanted to mention is that I appreciate the need to balance and the need to maintain or increase the POs and practice units participation in this initiative, but also the desire for our health plans as the funders of the initiative to show value for the funding. And just so with that in mind, I know that the straw man is looking at making the performance targets a little bit easier in 2017. However, I would like to mention that Blue Cross and Blue Care Network have been in some discussions about making some recommendations to make them slightly harder as opposed to easier this year. We were looking at increasing or making a recommendation for increasing the percentage improvement, as well as looking at the number of tiers for funding. So right now there's just the 2, the 85% or the 76.5%, and we were looking at potentially making some additional tiers for funding based on total score. And I want to get together with, and Bob, as you know, Blue Care Network, to talk a little bit more about our joint recommendation, but I did want to mention that we are looking at making a recommendation for harder performance targets rather than easier. So I just wanted to throw that out and let you know, and that's what we're thinking.
Everyone on the phone has a stake in this, so we really need to hear some additional comments, feedback, what you all are thinking.
I guess I'll weigh in again. This is Gina from Holland. I think that raising the targets may, at this point in time, is a good thing, and I think that we did that this past year, but it may inhibit some POs or providers that are on the fence about participating. And I think at this point what we need is more people to be evaluated on the level of patient satisfaction using a methodology that compares apples to apples. And so having more people on the bandwagon for MyPAC I think would be better than having fewer, and that performance levels that are unattainable might be a really big barrier for more participation.
Yeah, this is Robin again from Blue Cross. I just want to make sure you know that we're not talking about not funding at all, but continuing to fund, just maybe at a different level and trying to encourage a little more, as we've mentioned, skin in the game for the physician organizations.
Are any of the other payers on the line doing their own internal analysis and planning to bring to the work group a proposal down the road? I just wonder if we would be, if it would be advisable to take that into consideration in advance of making a decision on the targets as set forth today. I'm not exactly sure. I'm sorry, Lisa. I called in close to the start time exactly who's on the line.
This is Jeanette Dulac from HAP, and we were not working on a formal recommendation, but I did recognize that if you look at the percent improvement in round 2, the average is about 0.9, just under 1%. So we are being more lax with that attainment level, and I think that there could be some value from what Robin proposed, that maybe setting a top tier where high achievers are further incentivized, and maybe that would be a compromise. Leaving the target where it is at 0.6, but maybe including more funding for top performers above a higher level.
That's a positive incentive as opposed to lowering the amount the health plans contributed, sort of a negative incentive.
Right.
Thanks, Jeanette.
This is Jane from OMS. I just think that while we want to always encourage, and we all want our practices to do better and then have improved scores, but I think we would have to look at it as far as what specifically those targets would be. So what the Blues or what any of the other plans are doing, and as far as how much it would cost for if it would be feasible for us to be able to do it. If we feel we can get that, we can attain that and make it work. That I think would be the biggest thing for us, because technically, they haven't had to be part of this. This is not a mandatory thing. This is a voluntary thing for the offices to do, and we want to encourage them, obviously, to continue to do better, but it's going to be hard for us if the cost is super high.
Well, thanks, Jane. It really helps to hear what the POs are thinking.
How about some additional thoughts from POs on the phone?
This is Carla from OSP. I mean, I do agree with what Jane is saying as far as the additional burden on cost, but I also know that a year ago, this is where we all sat and we agreed to this particular approach a year ago. So I think it's fair as it relates to you're comparing us to our own peers that are participating within the program, opposed to being compared to what's going on nationally. I don't know if maybe in looking at some of the, I'm looking at the results, Lisa, that you sent us out in September, so I don't know if maybe the approach is if we're doing better locally, or I guess I would maybe say take the lesser of the two. I don't know if everyone's okay with that. So if we're doing really well locally, but the national standard is actually lower than where we're at, just to allow for some give and take, so to speak.
Well, actually, it's the other way around. Is
it the other way around?
The national levels are higher than the MIPEC 50th.
Okay.
As an example.
Yeah, from what I'm seeing on the report, it appears that way. I just haven't analyzed exactly every measure.
Yeah.
Are there thoughts from other POs reacting to the comments made by the two health plans so far?
I mean, this is Tom Senkwitz. I appreciate both sides, I guess. So I hear what everybody's saying. I agree with, I think it was Gina and Holland that basically said, one of our primary goals still to encourage participation. So how do you balance that with setting targets and improvement targets? At the same time, I hear Robin and the others, if I'm a payer, we've been talking about improvement for some time, and when do we begin really pushing that more? So I think it's a fine line, and I think it's a healthy tension. And how that eventually plays out, I'm not certain, because it's challenge. That's the fact, I think, and we find ourselves in the situation. And on one hand, I lean towards one approach because I do think we're hoping and looking for greater participation so we can compare across the state in an apples-to-apples manner, and by increasing the targets, that might go totally against what we're trying to accomplish there. At the same time, the health plans have been talking about it. We've been talking about it for some time. And when do we pull that trigger and just say that's the way it's going to go, because that's the way it should go from that perspective. So, I don't know what more to say than I can see it from both sides.
This is George with BCN, and Rob, I think you brought up a good question. Obviously, BCN and Blue Cross are working together to put together the proposal. And HAP did voice. Are there other carriers? I think you posed a really interesting question. Is this being looked at by the other carriers, or is the program just kind of seen as it's going to take its own course without real active participation on the carrier part? So I'm interested to understand, how the other carriers are looking at the program, because it's something that we look at, seriously when these proposals come out, and what the, long-range plan of the program was, and what it's going to take to get there, and making sure that they're, following a path that leads us there. And there are conversations, again, as it was mentioned, when we look at these year over year as to where we were a year ago, and then we didn't get the results we expected. So it's more of a reactive approach to, like back down some of that. Which, again, does that really get us to the where we're wanting to go. And understandably, it's an area of financial for some of the practices, and there's certainly conversations that have to take place for participation, but also that dollar value can't be the only value that's placed on participation when you're ultimately working for a different goal, and that's patient satisfaction and patient experience.
This is Gina from Holland again. I wanted to add another layer of complexity, not by choice, but just because this is something that I'm thinking about also. As a PHO, we are evaluating the cost of moving to more of a continuous sampling. This is something that our offices are begging for because they feel that the annual is just not cutting it for us, but we know that within the MyPEC initiative, we'll have to either bring everybody up to continuous sampling or not keep everybody at the annual. If performance expectations are set at a higher level, which would decrease funding for the MyPEC initiative, it would inhibit us from moving to more of a continuous sampling, which in theory should help us improve our rates because we'll have more timely and actionable data and information to make these decisions for. Just wanted to add that also because that's something that we're looking at this coming year to, can we afford to survey more often?
That's a relevant additional factor to add into the mix. And moving to continuous sampling, and we'll be talking a little bit more about that in the updates, but that has long been the direction that we're hoping MyPEC moves, PO by PO. So the just to perhaps not to get into a different discussion here, but responding directly to one of your comments, Gina, I'm not sure whether you were talking in terms of increased cost for doing continuous surveying, internal costs in terms of staff time and the like to produce the sample frames more frequently than once a year. But in terms of the cost from the vendor, it's cost neutral as compared to whether you do it once a year or once a month or something different.
But Gina does, I want to highlight one of the points Gina said. From at least the NRC perspective, if your entire PO is not ready to collect and turn in data on a monthly basis, then at least from the NRC perspective, the cost would be different. They need the whole PO to be able to do that in order for you to move to continuous surveying.
Yeah.
Hello, this is Joan Kirk from WMP, and I'm jumping on late on this conversation. But I was just thinking that if I were to go to my practice and say we want them to improve by 0.6, that's not going to be very motivating for them or for me to get them motivated to be involved in some activities for improvement when that's all we're expecting, that percentage of improvement. So I'm a little concerned, taking aside the cost, but that's setting our goals a little low for the expectation we have for improvement.
So Joan, just to make sure we understand, you think that setting the percentage point improvement at 0.6 is too low, that it's not very motivating?
Correct.
Yeah, thank you for that comment.
Yeah, this is Robin from Blue Cross, and I just wanted to mention just some initial modeling that we did, looking at, I mean, I'm not saying this is where we're absolutely going, but we were looking at more of a 1.5 to 2% suggestion in terms of the improvement. So, yeah, the 0.6 is definitely in a different direction than we were sort of leaning. And even when you look at 2%, making it a 2% improvement, just based on the modeling and based on the results from last year, it's not that much of a stretch. So I'm just throwing that out there.
Lisa or Bob, can you go back to the difference grid, please?
What did you say, Carla?
Can you go back to the grid where the scores were? Because you also calculated what the differences were.
The differences? You're asking what the differences were?
Yeah, no, I'm looking at them right now. You already have them there.
Yeah.
As far as their improvement, I
think that's a good point. So if you skim down the improvement columns and how many POs would have been able to achieve the goal if the percentage point improvement had to be 1.5 or 2%.
And that gets back to kind of, I think, what Holland and the Holland PO and Tom were saying is the hope and goal is to acquire more participation, not scare them off. As I can appreciate the fact that we need to have like a 1 and 2%, but if we also reflect back on we had those speakers come in and do a presentation, and this is not a normal measurement that we can easily have the needle move aggressively, you know, versus going out and working with physicians and, you know, telling them you need to capture your A1Cs or code your BMIs, or this is a little bit different. This particular measurement is out of our physical control, other than encouraging patients to complete the surveys, and also a lot of it is derived off of patients' perceptions. So my thing would be is looking at these differences when we try to make the decision of whether 0.6% improvement is the appropriate target, or we need more, or whatever the decision is.
I'm going to throw one more thing in there. This is Gina from Holland again. In terms of the different domains that we're looking at and the improvement, if we're looking at 1 to 2% improvement, for provider communication, for example, 2% is the difference between 50th percentile and 75th percentile for some of these measures.
Yes, you were correct in that.
Looking at that spread, would it be appropriate to make different amounts of improvement by the spread of kind of the scores within the different domains? I don't know, but across the board, that's going to be hard for some of the domain scores to improve that much, more so than other domain scores.
I actually like where you're going with that, Gina. Is there a way, because everyone's scores also are dependent on their volume. I don't know, Lisa, is it hard to unhide the volume?
Yeah, that's not included in this spreadsheet, and one of the things that we were concerned about doing that it could help. We committed to doing this in a blinded fashion, and if you know the volume, you might be able to kind of guess which PO scores those are.
Okay. I guess I like where Gina is going is you're doing it based on numerators and denominators, and that's kind of it. So based on Oakland Southfield physicians, I know we have a large preponderance of practices enrolled in this particular initiative. So, you know, us missing missing one or two is not as impactful as another PO that is, you know, missing one or two because of the sheer volume. Is that accounted for in this, that adjusted percentage?
No, the formula is the same regardless of whether you have 4 practice sites, 30. But it is.
You get where I'm going as far as normalizing it, because so when like the health plans are calculating rates and comparing physicians across their peers, they typically use the rate per 1,000 because then their membership normalizes. It gets normalized. So I don't know if there's a different algorithm that we can use for these.
Yeah, I think we'd have to think about that a little more. I'm not sure. Not sure that it's uncomparable the way it is, but more thought.
Mm-hmm.
But I do think the idea that I think I heard that maybe we should have different targets for different domains is certainly something that we can think about as well. We just kind of did it the same across the board for simplicity's sake, but certainly the scores vary a lot in terms of percent top box from one domain to another, so it certainly one could make the case that the targets should be different too. So that's something that we can certainly think about and play with a little bit. I think we're at our time limit for this, if not a little beyond. So what we will do is take all of this commentary, which we very much appreciate, into account. We will have some further conversation with the plans that are participating in MyPEC, and we will come back to the January meeting with a what I presume will be a revised proposal for round 3 targets that we will be asking all of you to support. Any final comments before we move on? All right, thank you very much. And I will turn it over to Lisa to take us through the proposed public reports for round 2 or 2015 results.
Thanks, Bob. So attachment 4 in your packet was a draft of the text that's on the website showing the changes we would make to the current text for the new website update with round 2 data that we hope to complete before the end of the year. And actually the version that I'm showing you on the screen is actually a little bit different than what was distributed with your meeting materials in your meeting packet. And basically what you could do is even go to the website, see what's there, and really the biggest changes we're making is to change, as you see here on the screen right now, where it says the results are for 2014, we would change that to 2015, and survey responses are currently being collected for 2016. That would be updated. Most of the rest of the text we're proposing to leave the same. We have a few minor tweaks in the section that appears in the About the Survey section, describing what a physician organization is and why physician organizations are important to the viewer. And you can see on the screen or in your attachment under the question, why are physician organizations important to me? We just proposed some updating of the text to make it relevant to the patient survey or patient experience of care survey results. The wording that we had in the past was more broad and probably described work that POs were doing a little earlier in time than maybe is true currently. So I'm interested in any feedback you have about what sort of examples we want to include in the bottom of what you see here on the screen, examples of what POs are doing to work with providers. In this example, we've said to improve provider communication, while others may be focused on timely appointments, just to use 2 examples from patient experience of care surveying. And in addition, you can see we've changed the word physicians to providers in that section so that it's all inclusive. Those are the only real changes we're proposing. And I'm going to use a screen view right now that shows you what it looks like actually on the website. So the text that's at the top of this website right now, we're not proposing to change except for updating the years referenced. And then as you go into the About the Survey section, the wording on why are physicians organizations important to me is what we're proposing to change. Those are the major changes. Everything else that you see me scrolling through on the screen would be pretty much the same as it is now. We have to update the list of POs. So I guess I'll pause and ask, does anyone have any comments about the proposed changes in the wording that you saw in attachment 4?
Lisa, this is Jenny. The one thing I would like is when you had about improving communication, I think I'd like to consider removing the word provider there or trying to broaden that, because the 3 areas we're really focusing on is helpfulness and courtesy of office staff, access, getting appointments in a timely manner, and then provider communication. So I would just either, or let's find a way to introduce that other core domain into this example, and I'd be happy to think about that and give you some further feedback after. That's the only thing that I noticed, and if we're going to call out those 2, I don't want to necessarily miss the last.
Okay, we can easily do that. Thank you. I do encourage you to look at the way that your PO's name is listed in this attachment 4. So I've got the groups for the West-North region displayed here. You can see we've deleted some and we've changed the wording of one of the PO's names there. And then for the Southeast region, we've added some and changed one PO's name. So please take a look at your PO's name and let us know if for some reason there's been a change or we need to update it. Rich and Erica, this may apply to you too. I know that we should probably update your PO's name.
Okay, we'll take a look. Thank you.
Thanks. Okay, well, I'm going to send out the revised attachment 4 that was different than what was in your meeting materials. It's just slightly organized slightly differently, a little more concise. And I will remind you to make sure that your PO's name is accurate. And we'll be moving ahead with the website update in the hopes that we can, as I said, get data for round 2 posted before the end of this year.
Great, thank you, Lisa. Nice to see the commitment and the movement to public reporting. We're getting there, that's for sure. So our next status update are just, it looks like a catch-all of various updates and announcements. Bob, would you please walk us through those so that we're all aware of key things in the near term and deadlines approaching?
Yeah, this is Lisa. Jenny, I'll walk through some of these updates, and I can do that pretty quickly. So on your agenda, item 5A, we've heard from the CAPS database that they're looking to streamline and try to tighten up the timeline a little bit. So this would mean that the vendors would be submitting the data to the CAPS database in between February 20th and March 3rd, which is earlier than it was last year. And this would mean we'd be asking all of you to sign your CAPS data use agreements a little bit earlier in the year. Those are the agreements that allow your vendors, NRC or Press Ganey, to submit the data to the CAPS database. And it includes a list of your participating practices that we put together for you to try to make that easy on you. So that would happen a little bit earlier in the year, right after we get back from the New Year's holiday in January. And the impact of that is that we would hope to receive the Michigan-specific data and the national data on the CAPS database earlier in 2017 than we experienced in 2016. We got the national results in late July and the Michigan results in mid-August, and all of that would move up by a few weeks at least. So we think this is a good thing, and we wanted you to be aware of it. And I guess with each of these status updates, I'll just pause and see if there are any questions or comments before I move on to the next one. All right, well then item 5B, the status of health plan payments to the POs for the survey costs. You should have all received your Blue Cross payment on your PGIP payment that came October 31st. So you should have all received your payments from Blue Cross Blue Shield. The HAP payments went in the mail on November 4th to all but 3 POs for which HAP needed W-9s. And I think each of those 3 POs have specific messages from me this week that you should know what's going on with your situation. Those should be going out very shortly, if not already. Blue Care Network assures us that checks would go out before the end of this week. And for Health Plus, which is now known as HAP North, we're checking into that. Most of you have a very small portion of your payments from that health plan, but that's one plan that we're still trying to determine when, if those payments have not gone out yet, when they will go out. Any questions or comments on health plan payments to the POs?
Lisa, you cut out a little bit. After HAP, between HAP and Health Plus, what was the other payer status you shared?
Blue Care Network payments are, we've had commitment from Blue Care Network that those checks, if they have not gone out already, will go before the end of this week.
Thank you.
Yes. Any other questions or comments on health plan payments? Okay, item C, I actually do not have a final count to give you yet on PO and practice sites. Our preliminary count before all of the deleted practices was 1,041 providers and 257 practices. However, there are practices that were unable to complete their sample files and submit that to the vendor, or so that the vendor could randomly select the providers to get surveys. So those numbers are going to go down by several practices, and I will have a final count coming up in the near future on that, but at least you know the starting point for round 3, which is an overall increase from round 2. Item 5D, the continuous sampling, we kind of touched on that already, but just to reiterate for everyone, the NRC clients, we've been told that you can move to continuous surveying for the same cost that you're currently doing with the point-in-time surveying, and that would be specifically monthly surveying would be the option. And the caveat, as we mentioned earlier, is that the PO would need to make sure that, number one, they are submitting clean files to NRC, that they've been successful and have been able to routinely submit good, clean files with the data for your PO, and secondly, that all the practices in the PO would need to be able to do the monthly file submission. So if you have some practices that can and some that can't, you wouldn't be able to move to continuous surveying until all of the practices can do that. But the cost ramifications would not change. It would be the same cost that we're currently incurring, $8 per completed survey for monthly continuous surveying. And I will definitely pause here to see if there are any questions or comments about continuous sampling and surveying.
Just to add another facet to this, we have been told by NRC that this is an all or nothing proposition for each PO, that all of them have to do point in time or all of them have to do continuous. A question that has not been asked nor answered at this point is if a PO was willing to pay more, would NRC break it up and do some one way, some another way? I have no idea what the answer to that would be, but theoretically, that's an option.
So we will pose that question to NRC and let the POs know. Okay, point E, 5E on your agenda, basically is just to let you know that we've invited we have been in discussions with SIM about the potential for the Michigan Patient Experience of Care initiative to meet the patient experience needs of SIM, and we're hopeful that that will have a positive conclusion, but we wanted you to be aware that there are some collaboration discussions in process, and we'll keep you posted as those move forward. And then lastly, we've talked previously about a shared platform for communications, and we've talked about the Health Doers platform, which is sponsored by the Collaborative Health Network. And this would be a platform or a network where people can share resources, but also a forum for discussions and sharing of best practices and learning. And we would do that as a private group among ourselves, and then we would be able to determine which things we wish to share with the broader community. It's a national group of people that have a patient experience of care section to the overall website, so we can keep our own things private and decide what we want to share on the public website. So the way that this would work is that we would provide names and contact information to the Collaborative Health Network for setting up as participants in our own private Health Doers group on patient experience. And you would, as a participant, have the opportunity to look at resources and participate in discussion forums. There would be a self-guided orientation and videos and getting started on how to use the Collaborative Health Network platform, but it would be a private group. We would have a searchable directory of our members on our private site, and an events calendar. All of those things would be available through the Health Doers platform. We would hope to have regular updates and posts and discussions going, and Bob and I would be keeping an eye on that and making sure that it stays current. You would get an invitation to join with information explaining how to get on the network, and you would periodically receive notices from the Collaborative Health Network about information and items that have been posted on the general population website that's available to all of the groups. So we're anticipating this to happen within the next month, and we wanted you to be aware of it. We've discussed it previously, and we're moving ahead with implementation, and we wanted to give you the chance to ask questions or clarify how this would work. Over time, in addition to the work group members, we would hope that some of your practices will want to join, and we would be adding them as they express interest in being part of the Collaborative Health Network Health Doers platform. Any questions or comments about how this would work? Are you anticipating this will be beneficial to you and your practices?
Hi, Lisa. It's Jenny. Absolutely. We're really looking forward to that so that we have that one-stop shop for resources to set up a structured way to message and guide our practices to the components that link more directly to what their area of opportunity is versus, I think, the broad stroke approach that we've used to date to promote improvement and build our community collaboration at a state level has been helpful. I think this will also get to the point that Tom and some of the other organizations who've been involved in this work longer than some of us can also use it as a way to customize and drill into where their greatest need is. So, so thank you. Please keep us posted as you do so well through email when things become available. So at a PO level, I think we need to get in there, familiarize ourselves with it, and then put together a strategy for using it with our practices. And that strategy plan will be important for us all to bring to future work group calls.
Great. Thanks, Jenny. So the last attachment is a schedule of meetings for 2017, and the proposal is to continue with the type of meeting schedule we had in 2016, where we meet on the third Thursday of the month on the odd-numbered months, and we would have an in-person, fourth Thursday of the month, and we'd have an in-person meeting in March and continue with our webinars every other month. So you can see the actual dates on the attachment there, and unless anyone has any other suggestions, we'll move forward with that schedule and send out Outlook meeting notices to everyone in the coming week.
Very good.
Perfect. Thank you, Lisa and Bob. I'm going to go ahead and wrap up the meeting briefly for all of us. It was a tough meeting. We get through a lot of tough topics together. I appreciate everyone's voice and input as we make difficult decisions along the path of advancing the core principles of MyPEC. So in saying that, I think we all have some things to think about. There will definitely be off-meeting conversations and dialogue between key stakeholders so that we come back together in January and are able to agree on a format moving forward, particularly as it relates to the performance targets and sustainability. Always challenging work, but I know this group can get through it. So in saying that, reflect on those ideas. Please share other ideas or feedback. Give us a call. Send us an email at any time. And with that, I wish you all a wonderful holiday season as we enter into it. And we will keep you posted as things change throughout the coming weeks and months.
Thank you very much,
Jenny. Thank you, Jenny,
everyone.
for that wrap-up.
Thank you.
Thank you.
Thank you all.
Happy
Thank you.
holidays.
Bye-bye.